Thank you, Axel. All right, we're in the home stretch of the day, so I really appreciate all the outstanding lectures and the great discussion today. So I get to give update 4, which is novel therapies beyond immunotherapy. My disclosures, if I can get to them, have not changed since this morning. Not sure that this thing is working. Oh, well. Maybe so. All right, so I think we all envision a day where maybe immunotherapy or immune checkpoint therapy will be the only treatment that we give for all GI malignancies. But of course, we know now that as it stands right now, that immune checkpoint therapy, while effective in some amount of patients, is certainly not effective for a majority of the patients with GI malignancies. And so targeted therapy is going to continue to be play an important role in the treatment of patients, particularly with metastatic colorectal cancer and metastatic disease for GI malignancies in general. So there are a ton of novel targeted agents that are currently in development for almost all targets, but I'm trying to keep this a little bit more relevant for GI malignancies. So of course, with the amount of RAS and RAF mutations that we see, particularly in colorectal cancer, we'll discuss about those two genes, and hopefully we'll give you some promising data, or at least a promising path forward. The conversation will then take a downward turn as we talk about FGFR and MET, and this will be the lowlights of the presentation. But there's been enough interest in GI malignancies for these two particular targets that I think that an update on the recent clinical trials is important, and hopefully we'll wrap up with an upswing and maybe with some more optimism regarding Wnt and then targeting gene fusion or gene rearrangement events. All right, so for targeting RAS. All right, so there have been numerous strategies to target RAS, and as opposed to a 20-minute talk, this could be a 2-hour discussion. But in the 1990s, a lot of focus was kind of put towards inhibiting the plasma membrane association with KRAS with farnesyltransferase inhibitors. The unfortunate thing about farnesyltransferase inhibitors was that they were actually effective in targeting HRAS, but unfortunately not very effective in targeting KRAS. And so this was a drug class that eventually failed to target RAS mutant cancers, including colorectal cancer. KRAS itself was an interesting target to hit because, well, if it's mutated, can we just hit the gene itself? The problem with that is that RAS is largely being considered to be an undruggable target, and that's because that RAS-GTP interaction is so tight that it's hard to actually get a drug that can successfully compete in that area. I actually put G12C in as a question mark because this theory that RAS is a completely undruggable target may be being challenged right now, as there have been researchers who are focusing on actually being able to successfully put a drug in that binding pocket in G12C mutant KRAS. Having said that, a lot of, or most of the research and paths forward have really looked at inhibitors of downstream effector signaling, trying to say, well, if we can't hit RAS itself, can we hit the downstream effector signaling to stop the signal transduction? I'm not sure that this remote control is currently working. So I'm showing you a really simplified version of the MAP kinase signaling pathway. And so if this was all we had to deal with in terms of targeting RAS, then one might think, well, if we have a successful RAF inhibitor, we might be able to shut down cell proliferation survival. Same with if you had a MEK inhibitor or an ERK inhibitor. This was proven. Okay, thanks. This was proven easily wrong with this phase 2 trial looking at the effect of capecitabine versus a MEK inhibitor, selumetinib, or AZD6244, in metastatic colorectal cancer patients, and these are pre-treated patients. And as you can see here, the Kaplan-Meier curves are essentially on top of each other with median progression-free survival of 81 and 88 days. And so certainly nothing that was super impressive, and also proved that MEK as a single agent probably wasn't a viable path forward for metastatic colorectal cancer. Next slide. So the issue being that RAS signaling is unbelievably complex, and so this was actually the latest figure from the National Cancer Institute RAS initiative, showing not only how complex RAS signaling is, but how complex the feedback mechanisms are as well. So one shouldn't be surprised that if we hit one node within this pathway, that we shouldn't be surprised when that alone doesn't completely stop cancer cell growth. Next slide. So there are a lot of selected ongoing trials in KRAS mutant colorectal cancer. A lot of these are looking at either biologic combinations, as well as biologic and chemotherapy combinations. And so combination therapy seems to be the pathway forward in terms of successfully treating KRAS mutant colorectal cancer, and that's what I want to focus on the next couple of slides. Next slide. So in terms of combination strategies for KRAS mutant colorectal cancer, there have been some promising research, and I want to show you at least two different types of combination strategies that have shown promise, at least preclinically. And so Ryan Corcoran's group has shown that the combination of selumetinib and a BCL-XL inhibitor, ABT263, was successfully able to cause tumor growth inhibition in patient-derived human tumor explants. And a phase 1b/2 clinical trial is currently accruing. There's also promising data regarding the combination of a MEK inhibitor and IGF-1R inhibitor, and this again is selumetinib with an IGF-1R inhibitor OSI 906, again showing tumor regression in a colorectal cancer patient-derived explant. I'm also going to show you data from Gail Eckhart's lab looking at colorectal cancer cell lines that are resistant to the MEK inhibitor selumetinib, and this is a pretty busy figure. But what you're seeing in this figure is actually a synthetic lethal screen and gene set enrichment analysis showing that in cell lines that were resistant to the MEK inhibitor selumetinib, you saw increased expression of multiple Wnt genes, suggesting that the Wnt pathway was actually serving as a resistance mechanism to selumetinib, the MEK inhibitor. And this included genes in the Wnt canonical pathway as well as the non-canonical pathway. When we tried a combination of a MEK inhibitor and a Wnt inhibitor in a KRAS mutant colorectal cancer patient-derived explant, what we saw was that the combination of the two drugs was able to inhibit tumor growth, but when you looked at each single agent alone, a Wnt inhibitor or a MEK inhibitor as a single agent, there was no tumor growth inhibition. Interestingly, when you started the combination in both single arms, you actually saw dramatic tumor growth regression or tumor regression in these models. And we usually try to treat these models to resistance. And as you can see, we took some of these models out to 200 days and there was no resistance. Next slide. All right, so there is a phase 1 trial of a MEK inhibitor and a Wnt inhibitor that's ongoing at the University of Colorado Cancer Center, and this is also being done through the Experimental Therapeutics Clinical Trials Network through the NCI. And again, this is extraordinarily preliminary data, but as you can see from this combination, there's a certain subset of patients that clearly are not deriving any benefit from the combination. There's also a subset of patients that are starting to show some tumor regression. So again, really early, these are just a handful of patients with KRAS mutant colorectal cancer, but certainly a little bit somewhat promising. All right, targeting RAF. So what we also know is that unlike cutaneous melanoma, where single-agent vemurafenib does have single-agent activity, we also know that when we've tried vemurafenib in V600E mutated colorectal cancer, that the response rate was roughly 5%. We also know now that there's significant preclinical data showing that there's a feedback loop through EGFR. And so the combination of a BRAF inhibitor in combination with an EGFR inhibitor in these preclinical models, and these are cell lines and patient-derived xenograft models, showing that the combination of vemurafenib and cetuximab in these models was able to show tumor growth inhibition, whereas each single agent didn't show any tumor growth inhibition at all. Next slide. All right, so there is a high response rate for the combination of a BRAF inhibitor, an EGFR inhibitor, and irinotecan. What I'm showing on the left is the vemurafenib phase 1 that shows a 5% response rate. The combination of vemurafenib, cetuximab, and irinotecan in a phase 1 study showed a 50% response rate, suggesting that this is a more active, albeit a much more toxic regimen. The historical response rate is less than 10% for cetuximab and irinotecan. So there are multiple trials looking at this idea of BRAF and EGFR inhibition. I'm just showing one example of a trial that's currently ongoing. This is SWOG 1406. Patients with a BRAF V600E mutation are being randomized to either cetuximab or irinotecan or vemurafenib, cetuximab, and irinotecan, and crossover is allowed with the primary endpoint being progression-free survival. And this trial is probably going to complete accrual this year.
It just stopped today.
It just stopped. There it is, up-to-date information. Next slide. All right. This is where the talk takes a turn for the worse. So targeting FGF, FGFR has certainly been of significant interest in GI malignancies. And fibroblast growth factor biology has been implicated in numerous diseases, not only oncologic diseases, but genetic diseases as well. FGFs and the receptors regulate proliferation, differentiation, migration, and survival, and they're also fundamental to embryonic development, angiogenesis, and wound healing. And this is a very ubiquitous and complicated pathway. There are 18 ligands and 4 receptors, and signaling occurs via the MAP kinase pathway as well as other pathways as well. In terms of FGFR implicated oncology indications is pretty much what looks like to be every single cancer, but included in this list are GI cancers that, of course, we're interested in: gastric cancer, colorectal cancer, pancreatic cancer, and hepatocellular carcinoma. There are FGFR implicated genetic diseases as well. There are FGFR aberrations that have been identified in GI cancers, and that includes activating mutations, translocations, amplifications, and alternative splicing. Granted that these aberrations in FGFR are in very, very small subsets within GI cancers as well, so sometimes finding these patients can be somewhat challenging. There are numerous anti-FGFR compounds currently in development. There are non-selective FGFR TKIs, and that includes a drug that you guys heard about during the lunch symposium, Vantictumab, which is a non-selective FGFR TKI along with others. There are selective FGFR tyrosine kinase inhibitors in the list here, and there are also antibodies and FGF ligand traps that are currently in development. Of interest, regorafenib, which is of course FDA approved for colorectal cancer, does inhibit FGFR1, albeit at a really high concentration. This is just a list of where kind of some of these FGFR compounds are currently in development, ranging all the way from phase 1 to phase 2 and phase 3. I will tell you that we've highlighted brivinib in colorectal cancer. A combination of brivinib and cetuximab in KRAS wild-type colorectal cancer was negative. In addition, I've also highlighted AZD4547 in gastric cancer. This was a phase 2 study in a biomarker-selected population. So this was an FGFR-amplified cancer, and that phase 2 was negative. And then there have been multiple ACC trials that have been negative, including an ACC trial in an unselected population with brivinib. So unfortunately, all the trials to date have been pretty unimpressive. Next slide. So in terms of the summary of the clinical experiences, there were some early signals of anti-tumor response, and most of these were in FGFR1 amplified cancer, especially breast cancer, but I will tell you that the phase 2 and 3 trials thus far have been really disappointing. The side effects of this class of medication mainly reflect VEGF targeting, with the exception of rare hyperphosphatemia, which we've noticed in some of our phase 1 trials. I will tell you that finding FGFR amplified patients is challenging. We aren't typically screening these patients for FGFR aberrations, and so getting this group of patients can be very tough, and there are continued ongoing phase 2 trials, but unfortunately interest in this target is starting to wane some. Next slide. All right. This is not going to get too much better, but talking about MET, which has been a bevy of negative clinical trials, which I'll have to show you over the next couple of minutes. Next slide. So there are a lot of MET pathway inhibitors that currently have been developed or are in development. There are HGF targeting monoclonal antibodies. Relatlimab is probably the most famous one. There's a c-MET targeting monoclonal antibody. Onartuzumab is one that I'll show you clinical trial data. And there are a lot of tyrosine kinase inhibitors that are currently in development, including XL184, which is known as cabozantinib, and I'm going to talk about that drug as well. Next slide. So relatlimab in gastric cancer is a drug that binds hepatocyte growth factor, the ligand. And this was a schema from a phase 2 trial showing promising activity in gastric cancer where chemotherapy in combination with relatlimab had better progression-free survival. Next slide. The ReloMet-1 was a phase 3 trial of relatlimab in gastric cancer. And unfortunately, as you can tell from these lines, which almost look like they're on top of each other, but there are actually more deaths in the relatlimab arm, primarily due to disease progression, which is exactly not what you want to see in a clinical trial. So when you look at overall survival and MET expression, so the hypothesis would be that, well, if we have a drug that targets MET, if we have higher MET expression, maybe our drug does better. Within the selected MET-positive population, the higher MET expression did not correlate with either poorer prognosis or better outcome with relatlimab, so certainly not promising activity at all. In terms of onartuzumab, again, this is a drug that inhibits HGF binding to MET and has also been looked at in GI cancers, including a phase 2 study of FOLFOX and bevacizumab with or without onartuzumab in colorectal cancer. And you see the schema here. There's also the METGastric study, which studied this drug in combination with FOLFOX in c-MET-positive gastric cancer. And unfortunately, the results are pretty much the same as what you've seen before. There are multiple Kaplan-Meier curves here showing you what the results are in the c-MET-positive population and the MET-negative population. And you don't really need a magnifying glass to tell you that all of these results are essentially negative with no difference in the MET-positive population and the MET-negative population. So a phase 3 study of onartuzumab plus modified FOLFOX6 in gastric cancer also showed no significant difference between the two arms. The addition of onartuzumab to modified FOLFOX6 was ineffective in either the intention to treat population or the MET-positive population, which means that the biomarker-positive population didn't benefit from the drug either. All hope is not lost. This is cabozantinib, which is an FDA-approved MET inhibitor. This drug also hits other targets that is approved for metastatic medullary thyroid cancer. This drug has been looked at in hepatocellular carcinoma. And this is data that was actually updated as far back as GI ASCO in 2012. But in this trial, 80% of the patients did have some tumor regression on scan, and 71% of the patients had disease control at 12 weeks. And so there was some promising activity. Unfortunately, this data is still not published. I will also say that there is some interest in cabozantinib in colorectal cancer, and a phase 2 trial is currently being developed. I'm going to wrap up with talking about two other targets, Wnt and then gene fusion events. For colorectal cancer, Wnt signaling is frequently altered. In fact, it's the most altered pathway in colorectal cancer according to the TCGA. We also know that Wnt signaling is incredibly complex, and so Wnt signals through the frizzled receptors, which then begins a cascade of signaling events that leads to beta-catenin stabilization and accumulation, and this results in gene transcription. That's the canonical or beta-catenin pathway. There's also the non-canonical or Wnt calcium pathway that Wnt also uses the signal to control cell motility, cytoskeletal changes, and adhesion. So there are antibodies that are being directed against Wnt, and so this is one of the first generation Wnt antibodies, and so this is a monoclonal antibody that actually attaches itself to the frizzleds. And so Vantictumab is a drug that targets frizzled 1, 2, 5, 7, and 8. There is preclinical data with Vantictumab. Can I go back one slide, please? Showing that in over 40 patient-derived xenograft models, there was a broad spectrum of activity. I'm showing you activity of Vantictumab in a colon cancer patient-derived explant, where Vantictumab as a single agent had similar activity to irinotecan, but in combination with irinotecan had increased tumor growth inhibition. So a phase 1 study of Vantictumab is currently wrapping up. So it does appear to be well tolerated. The pharmacodynamic effects are consistent with Wnt biology, and there are pharmacodynamic effects on bone, and this is evidenced by beta-CTX changes. And we also know that at extremely high doses, you actually see some bone fractures too. So this is a pharmacodynamic effect, but certainly was concerning during the phase 1 clinical trial. There is another class of Wnt inhibitors that are currently in development. These are tankerase inhibitors. And essentially, to make it a little bit oversimplified, the job of tankerase is to destabilize axin, which then stabilizes beta-catenin, and Wnt signaling is turned on. If you have a tankerase inhibitor, what happens is axin becomes stabilized, which then destabilizes beta-catenin, and Wnt signaling is turned off. So there are currently several different tankerase inhibitors that are in development. This is just an example of 4 tankerase inhibitors that are currently in development, and eventually we expect to see these in the clinic. I do want to show you a schematic of some of the Wnt inhibitors that are currently in development. And I will tell you that one of the concerns is that if you're too far upstream in terms of Wnt, but you have a mutation in APC or beta-catenin, that maybe just like a KRAS mutation in EGFR inhibition, if you target way up here, it may not matter if your signaling is turned on down below. And so one of the interesting things from this slide to show you is that there are actually Wnt inhibitors that target beta-catenin much further downstream in the signaling, which may make these inhibitors more effective, particularly for colorectal cancer in the future. So I'm just going to wrap up with this, targeting small biomarker-defined groups. So when we do next-generation sequencing on multiple GI cancers, what we're finding is that we're actually able to detect some of the gene fusion events that have caused a lot of excitement in non-small cell lung cancer, particularly NTRK, ALK, and ROS1. And so when you look at colorectal cancer, cholangiocarcinoma, even gastroesophageal cancer, you can actually detect a small percentage of patients that have these gene fusion events. And so the question is, if we can find these gene rearrangements, even if it's in an unbelievably small percentage of our patient population, can we successfully target these gene rearrangements? So I do want to show you, I don't have any clinical trial data, but I do want to show you a single patient that was treated with an ALK inhibitor. So this is an 86-year-old female with poorly differentiated colon adenocarcinoma, treated with FOLFOX and FOLFIRI, had disease progression. And when they did genomic analysis on her, they actually found an ALK fusion. So the patient was treated with ceritinib, which is an ALK inhibitor. And what you see here is regression of a periumbilical mass after about 19 weeks of treatment, and then a CT change showing a change in a characteristic of her primary peritoneal mass. And so again, this is kind of proof of concept that if you do find it and you treat that gene rearrangement with the right drug, you can have a positive clinical outcome. All right. So to wrap up, the pipeline of new agents in GI cancers does remain robust, but I would remark that the progress does seem very incremental, and there have been very disappointing results thus far with FGFR and MET targeting. The heterogeneity of the tumors is a serious problem, and you're about to get an excellent talk from Luis Diaz, who I'm sure will talk about that as well. Immune checkpoint inhibitors have only had a modest effect in GI cancers. Most novel agents have at least a biomarker hypothesis, test for MET, test for FGFR. But I will remark that nearly every novel agent that's currently approved for GI cancers has no companion pharmacodiagnostic. And unfortunately, that's kind of where we are. And I will say that our current clinical trial infrastructure is not built to deal with the problem of small biomarker-defined groups. And this includes ALK, ROS, and NTRK. And while clinical trials like the NCI MATCH trial are kind of built to start to address that problem, this is something that we'll have to certainly consider in the future, as trying to design a trial for 1% to 2% of our patient population with metastatic colorectal cancer probably isn't very feasible. And with that, I'll take some questions.